This week we're going to talk about case control studies. Now, a case control study is a type of observational study where we study persons with a disease of interest and compare it to a group of controls. So the group with the disease of interest are called the cases, and the group without the disease are called the controls. So a case control study is an epidemiological approach where the researcher starts by picking up cases. So these are people who have already developed a particular disease or outcome of interest. And then we pick a comparison group who are our controls. And these are the people who have not developed the disease but are similar in almost every way to the case. And then the researcher tries to find out if the presence of a particular exposure can be linked to the outcomes of interest. So again, a case is a person in a population or study group that has a particular disease, health disorder, or condition, and a control is a person that differs from the case only in that they do not have the disease being studied. So this involves two very different populations, cases and controls, and it has three distinct features. Both exposure and outcome have already occurred before we even begin the study. Second, the study proceeds backwards from effect to cause. Third, it uses a control or comparison group to support or refute an inference. So for instance, suppose we were interested in lung cancer and we wanted to see if smoking leads to lung cancer. We would already know whether or not people had developed lung cancer and whether or not they smoked. So what we would do then is take the number of people with lung cancer and we would trace their histories back to understand if they smoked, when they smoked, and all of that. And then we would look at people who had lung cancer and we would trace those people back if they did not smoke to look at them. So here's kind of how it looks. And this is a 2x2 table. So you first have, in your first column, you have the cases. These are people who have the disease. And then in your second column, these are the people without the disease. The first row is the people who were exposed, and the second row is the people who were not exposed. So what we would do then is put the number of people who have lung cancer and smoked in column A. Then we would put the number of people who smoked but do not have lung cancer in column B. In column C, we would put people who did not smoke but developed lung cancer. And in column D, we would include the non-smokers who also did not develop lung cancer. And from this, then, we would total it up and get the total number of people with the disease, the total number of people without the disease, and then we would create proportions to understand the percent of people who developed the disease and were exposed and were not exposed. So going backwards on this graph, we can see that there are cases and the control. So the exposed group represents the smoker, that's in orange. The non-exposed group is the non-smoker, that's in white. So if we wanted to see how many people with lung cancer were smokers versus how many people without lung cancer were smokers, we could use a case control study to find out. And then from that, we can also determine the odds ratio. So what are the odds of developing lung cancer if you are a smoker versus developing lung cancer if you are a non-smoker. So let's talk about the steps of a case control study. The first step is to select cases and controls. Then we go through a matching where we try to make sure that people with the most similar characteristics are in both groups. Then we figure out our measurement of the exposure, and then we analyze and interpret our findings. So in the selection of cases, all people in the source population who develop the disease of interest are a case. So that's our population. And so we then draw a sample of cases, and from there we define a clear definition of what the outcome studied is. We then look at both the prevalent and incident cases, because prevalent cases may be related to more survival with the disease than the development of the disease. Where do these cases come from? Well, medical records are the most easy way to examine it. So we would go to hospitals or doctors or clinics to get the medical records of individuals. We may also use census data or things like vital statistics for death records. Other things that we could use are NGOs that are population-based. So think about the American Cancer Society and the cancer registries that they have. That allows us to draw on individuals who have specific forms of cancer. Controls are a little different. We have to select these independently of their exposure status. That's not really what we're interested in. So controls have to be free from the disease under the study, and we don't select them based on whether or not they had the exposure of interest. So if we're thinking about smoking, we don't pick people without lung cancer and say, do you smoke or not smoke, and only pick the smokers. We just look and see whether or not they had lung cancer, and then we go back in time to find out, did they smoke? Okay. The controls have to be almost identical to the cases. So that means they need to be all similar ages, similar races, similar economic status, similar educational background, and so forth. Selection of controls is the most difficult process of a case control study. Now, where we get controls, it can come from hospitals, it can come from relatives, it can come from the neighborhoods that they live in, or the general population. When we select population-based controls, that means we're sampling the general population. If we are looking at healthcare facility-based controls, we are picking patients who have other diseases that are in the same hospital, but not the disease we're interested in. And then there are case-based controls. These could be friends, family members, or the neighborhoods that individuals are part of. The different levels lead to more bias. So let's talk about it. If we use hospital-based, these are the easily identified individuals. We can find people at a hospital and we can interview those people typically. Those people are usually really willing to communicate and they give really accurate information. But it's not necessarily typical of the general population, right? Think about who's in a hospital. That's not the healthiest people. So the people who end up in the hospital typically end up there because they have health factors that put them there, okay? If we use population-based, these are the most representative of the general population. These are also going to be the most healthy individuals. The problem is that controls that are drawn from a population-based system are often time-consuming and expensive. So there is also some opportunity that the exposure may not be the same as that of the cases, because depending on who is in your population-based sample, they may not have been in the same areas or geographic locations or workplaces as the people who were exposed. Neighborhood controls and cases tend to be really similar because of their residents, and it's easier to get to these people than the general population. The problem is, how many of you know your neighbors? Are you willing to sit down and talk with a stranger who comes to your door and wants to ask you questions? There's also some security issues because people may not want you in your home. You could end up in a situation that might be hostile to you, and these are not representative of the general population at all. The last group is the best friend control or the sibling control. These are family members and friends. These people want to help you. They are very cooperative. They are very easy to get a hold of, and they tend to be very similar to the case in every aspect because they're going to be similar races, ages, similar health backgrounds, similar exposure statuses, and things like that. The problem with this, though, is that we end up overmatching, and then we might wipe out some of the factors that could actually lead to a disease outcome. Now, how many controls are needed? Well, it depends on how many people are in your study. If you have very large studies, it should be a 1-to-1. If they're very small studies, you could probably get away with 1-to-4, but it really depends. The more you have, the less bias you will have in the study. Now, matching is the process by which we select controls in such a way that they are similar to cases with regard to certain outcomes and variables. This means like socio-demographic characteristics such as your age, your race, your gender, your political background, your religious affiliation, your educational background, your occupation, and so on. These are all known to influence the outcomes of disease. Think about the social determinants of health and how education and income affect whether or not you develop certain diseases. So we have to control for these things, or else we may get false positives. There are a couple of ways that we can match. We can match called group matching. This is where we assign cases to subcategories based on characteristics like age and occupation and then establish appropriate controls. Or we can do pair matching. This is where we find a control for each case and that each control similarly matches the case almost identically except for the disease in question. Now, there are three basic criteria we have to meet to select data on exposures. First, The definitions that we use have to be objective. They have to be clear, and we have to be able to reproduce whatever measurement we use for the exposure on every case. Second, we have to make sure that we are being accurate. The information that we're collecting has to closely as possible reflect the possible effect of an exposure. And third, we have to make sure we're being precise. We have to make sure that we are managing our exposure measurement so that we are upholding the highest quality of standards, so that we are not taking in cases that don't actually qualify or rejecting cases that should qualify. How do we measure our exposure? There are a lot of ways. We can interview people, we can send out questionnaires, we can look at hospital or employment records. So for instance, if we're looking at asbestos exposure, we can look at employment records to see if people who worked with asbestos worked there. We can find the people that worked at this employment place and look at them by their exposure status. Now, when we go to analyze this data, we are trying to find out first what the exposure rates among the cases and controls to a factor actually are, and then we are trying to estimate the risk associated with the exposure. These are called odds ratios. So here again is a 2x2 table. So you can see your cases in column A, your controls in column B, totals then in column C, and then your row 1 is your exposed, your row 2 is your unexposed, and row 3 is the totals. So let's say that we're looking at smoking and lung cancer. So in column A, we have the cases, and in column B, we have the controls. So let's look at this. So in row 1, we have people who smoked 5 cigarettes a day, and there were 33 people who developed lung cancer and 55 who did not, for a total of 88 smokers. In the second row, we had 2 non-smokers who developed lung cancer and 27 who did not, for a total of 29 non-smokers, for a total of 35 cases of lung cancer and 82 cases without, and an overall total of 117. So as I said, we had 33 cases of lung cancer. So let's look at it. What we would do is take the total number of cases in box A, which we see is 33, and we would divide that by the total number of cases with lung cancer to get a percentage of people who had lung cancer, which we can see is 94.2%. From the controls, we take everything in box B and divide that by those who were not with lung cancer. So if you remember, there were 82 cases of people without lung cancer. 55 of them were people who smoked, and so we can see there's 67%. So we can see that higher frequency of smoking is definitely a predictor of lung cancer, that a higher percentage of those who smoked developed lung cancer than those who did not smoke. So from there, we'd want to know what your risk of actually developing lung cancer actually is. And we saw that a greater percentage of smokers had lung cancer than non-smokers, but let's just look and see what we would do from there. So the first thing we would want to do is actually calculate the odds. Now, when I say odds, what we're talking about is the odds of an event that is defined as a ratio of the number of ways an event can occur to the number of ways that it cannot occur. This is what we call probability. So if we think about it like this, let's say we have an event that we're just going to call X. If the probability of event X occurring is called P, then the odds of that event happening is defined as P divided by 1 minus P. Now, this leads us to calculating then odds ratios. So an odds ratio is the ratio of the odds of an exposed group compared to the odds of those that were unexposed. And it can be best seen here in the 2x2 table. So what we would do then to calculate the odds ratio is we would take the probability that the case was exposed, divide that by the probability the case was not exposed, and then we would take the probability that the control was exposed and divide that by the probability that the control was unexposed. So here's kind of how it look. You would see the odds ratio then is equal to A divided by C divided by B divided by D, or A times D divided by B times C. Now, interpreting an odds ratio is one of the easiest things that you can do in any form of social science. If an odds ratio is exactly equal to 1, then the odds of exposure among cases and controls are the exact same, and exposure is not associated with the disease. If the odds ratio is greater than 1, then we are saying that the odds of exposure among cases are higher than controls, and exposure is positively associated with the disease. When we say a positive correlation, it means that both move in the same direction. So as X goes up, so does Y. If the odds ratio is less than 1, we are saying that the odds of exposure among cases are lower than among controls, and that this is a negative association or negative correlation, which means that as X goes up, Y goes down. So an odds ratio is an estimation of risk. If we go back to what we were talking about with smoking, if we divided the numbers in box A by box C, and then box B by box D, and we calculated it as A times D divided by B times C, we would see that we get the number 8.1, which means that the odds of smoking more than 5 cigarettes per day was 8.1 times more in lung cancer patients than those without lung cancer, or smoking was found to be associated 8.1 times more in patients with lung cancer than those without lung cancer. Like other studies, case control studies are open to bias. They can end up being biased depending on what we do. Now, bias is an error in our design, our conduct, or our analysis that leads us to make false conclusions. Now, one of the ways that we can have bias is in the selection of cases. When we select cases, we're often relying on medical diagnoses. Well, we all know that sometimes people write the wrong things down on forms. We also know that people enter in those I-10 codes and I-9 codes into computers that people then use to analyze, but is it possible that someone may have entered in the wrong number? So you could have a case where you have put someone into your study that actually did not have the disease, or you missed people who had the disease because they were miscoded. There can also be investigation issues related to the selection of controls. We often have to interview people and ask them questions about exposures, and we know that people are subject to recall bias. This is where people are less likely to recall an exposure unless something really bad came out of it. There can also be issues where we don't have enough depth in controls, whereas the cases have much more depth and nuance. Now, the most common form of bias we see in a case control study is confounding bias, and we talked about this when we talked about spurious correlations. This is where some third factor we haven't accounted for is causing an effect, and it may be causing the whole effect. So when we think about how some diseases have multiple risk factors, and those risk factors are highly related to each other, thinking about smoking and lung cancer, one of the predictors of smoking is economic status and education. So people with lower levels of education and lower economic status are more likely to smoke. So if we don't control for education, we don't control for economic status, we are not going to get correct conclusions. So this is what the solution is we have to do a really good job matching our cases and our controls. Let's talk about some of the strengths. First, it's really good for studying rare outcomes or diseases with really long latency. Second, it's relatively quick to conduct and very inexpensive. You're just going to usually hospitals or other clinicians' offices and making copies of medical records. It also requires comparatively few subjects compared to what we would see in other forms of studies. We can also look at multiple exposures and risk factors at the same time because we're starting with the disease and we're working back to see what exposures may have led to the disease. But some of the weaknesses are recall bias. That's the big one. People don't remember things, especially if they don't develop a disease. You might have someone who may have smoked and they stopped smoking, but they can't remember how much they smoked 20 years ago. So they're just going to give you a number. It can also be really difficult to find an appropriate comparison group. And the rates of disease in exposed and unexposed individuals cannot actually be determined using a case control study. We also cannot differentiate between causal factors and associated factors. We just know that these factors are associated with the outcome of the disease. This is not at all useful for evaluating a prescription drug. And we could run into issues where the cases and controls are not representative of the general population, so we can't generalize it to a larger population and say that it's indicative of everybody who does X and develops Y. Let's stop here.